Hi everybody, Melissa Temple here. We're going to move on to the PA insertion and wedge portion of our instruction. Here is an example of a Swan-Ganz catheter. I just want to make sure and remind everyone that it is heparin coated by the manufacturers. We're going to first start with preparation. So what you want to do is obtain consent and make sure that it's placed in the patient's chart. You want to gather all your supplies, and I have a list right here that you can read. Next, you want to set up your transducer, prime all ports, connect the cables, and zero it to the monitor. And then the last thing you want to do is perform a procedural timeout at the bedside. Now that we have that all done and completed, we'll go ahead and work with the provider and then actually insert the PA. We have our physician here who's ready. What they're going to do is take the Swan catheter out of the package and pass the triangle with the 5 ports or 5 lumens to the nurse at the bedside. The nurse is now going to take the triangle and say aloud to the physician that this is no longer sterile.
This part is no longer sterile.
Now that the nurse has the triangle with all of the lumens in his hand, what we're going to do is flush each of the ports. So first we're going to start with the PA or yellow transducer port. What he'll do is first connect the transducer to the port and then flush the catheter. So you want to flush the catheter by squeezing the transducer flush tabs and notifying the physician that you are flushing.
Flushing the PA.
Now that that's done, you want to repeat this with the blue port or the CVP port.
Flushing CVP.
Now that that's done, you want to flush the VIP port. So what the nurse will do is grab a 10 cc syringe of NS with a MaxiPlus connector that's already been pre-flushed and connect it to the white port. And once that's connected, you want to begin flushing and notify the physician again that you're flushing the VIP port.
Flushing the VIP port.
Okay, now that the line is flushed, what we want to do is test to make sure that the waveforms are working correctly. So what the bedside nurse is going to do is announce to the physician that they're testing the PA port first while wiggling the catheter and observing the monitor for artifact, or what we call WIP.
Testing PA port.
Then what you want to do is repeat that same step with the CVP port.
Testing CVP port.
Okay, now we're going to test the balloon prior to insertion. The physician will hand the specific 3 ml syringe to the nurse. I want to make sure we maintain sterile field while this is being passed over. Now the bedside nurse will draw 1.5 cc's into the specific syringe and attach to the balloon port. Now you want to unlock the balloon port which means that the two red lines are going to be matching up. Now you want to inflate the balloon slowly, and when you're completely inflated, notify the physician that the balloon is up.
Balloon up.
Now you want to deflate the balloon passively, so basically you don't pull back on the syringe. Now what happens sometimes is that the balloon gets stuck in halfway inflated. What you can do is gently tap back on the plunger part of the syringe until the balloon is completely deflated. Now you want to lock the balloon syringe, make sure that the two red lines do not match up. Now what you want to do is ensure that the provider has placed the CathGuard catheter contamination shield, the accordion-like plastic cover, over the Swan before insertion. Okay, so now you want to get your monitor ready for the insertion. Sometimes the provider may ask for a larger waveform screen, and that's depicted right here. First, what you want to do is highlight and select the PA option, which is right here on the monitor. Then you want to highlight the PA insert and wedge option. Now what's going to happen when that comes up, all of your waveforms will disappear, but your numbers will remain on the left-hand side. So now we move on to the RN's role. So what you want to do is monitor for EKG changes, which includes ectopy or lethal arrhythmias. And if you notice them, you want to notify the physician right away. Next you want to do is monitor for the waveform changes that will occur during the insertion phase. So first, you go through the right atrium. Here's the waveform here. Then you want to go into the right ventricle, and your waveform changes. As you can see here, it's much larger. If you hang out in the right ventricle for too long, basically it's tickling the heart, and the patient can go into VTAC. So you want to quickly make sure the physician moves along into the pulmonary artery here, where the waveform changes again. And then they'll go one step further to make sure that they're in the pulmonary wedge position, which right here your waveform will be flattened. And then they won't stay there, they'll actually pull back and hang out in the pulmonary artery. During this process, you as a bedside nurse want to make sure that you participate in this. So you'll be there for the inflation and deflation part. You want to make sure that you listen to the provider's instructions and use closed loop communication. So basically when the catheter is being advanced or repositioned, the physician will notify you to inflate the balloon or balloon up. Then you want to use communication and state that the balloon is up. During any withdrawing of the catheter or pulling back, the physician will notify you to put the balloon down. You want to make sure you clearly state that the balloon is down. So when the balloon is not in use at any point, you want to make sure that you have the balloon in the deflated locked position. So this means that there's no air and that the two red lines do not match up. And this helps communicate to other nurses that there's no more air left in the balloon, that also if the patient were to get up and move around, that there would be no air that accidentally was injected into the balloon port. So like I said, you want to make sure that the red lines are not matched up, and then after this is locked, you want to remove the syringe, empty out any air, and then reattach to the balloon port and leave it as be. So once the catheter is placed, you want to make sure that you document, just like we do for any central line that's placed. In Pisces, you're going to include the insertion site, the date of insertion, And then the new thing you want to do is make sure you include the external centimeter mark of the PA catheter, like depicted right here. And we showed you that in the last presentation. And then you want to make sure that you actually measure at the beginning of your shift as to where the centimeter marks are in case there's any movement or migration of the catheter. So you want to start measuring here, basically the end of the introducer site. Then you want to chart that. All right. So we'll move on to care of the catheter. Once the catheter is placed, you want to make sure that you obtain an X-ray. You want to make sure that you use pink tape to secure that triangle piece to the chest. At no point should we be using tape on the cath-guard shield. If you tape over that plastic piece with any of our tape and you pull the tape off, you'll actually create little microscopic holes which can actually lead to infection or basically contaminate the catheter itself. The next thing you want to do is make sure that you zero your lines at the beginning of your shift like we do with every patient. You want to perform a PA wedge cardiac output every 4 hours at the beginning of your shift and PRN. And then there are specific patients where you don't want to perform the PA wedge, and I'll talk about that in a slide coming up. And then obviously if you notice any changes on the monitor or with the catheter itself, notify the physician immediately. So we move on to talking about possible complications. Just like any central line, you have the complications of infection, occluded ports, but with PA cath specifically, you have complications of dysrhythmias like we talked about earlier, VTAC, things like that that basically are caused by the catheter irritating sections of the heart because it's either migrated or just being there. And then also pneumothorax can commonly occur like any central line plate that's been placed. Air embolism can occur also. If the balloon ruptures at any point, then that can cause an air embolism. And this, you could possibly see blood in the syringe, that would give you an indication that the balloon has ruptured. And obviously if we have any improper flushing of the line, that institutes little bubbles of air. Next, you talk about pulmonary artery rupture. This can occur basically during placement of the catheter because either the balloon is not up or the balloon is either inflated or deflated at the incorrect time. Or if the balloon is overinflated, if you use more than 1.5 cc's of air. Or just basically overuse of the balloon if the catheter has been in for a long time. Pulmonary infarction can also occur, and this happens if the catheter migrates into the wedge position and then sits there. So basically the catheter then is occluding area of the pulmonary artery, which can lead to decreased blood flow or infarction. So that's why it's really important to monitor your waveforms and to notice if any changes occur. What else? Also, if the balloon is inflated for too long, you don't want to leave that because that also decreases blood flow to that area. Then the last thing is if a thrombus forms around the catheter itself. Next, pulmonary thromboembolism can occur, and this can occur when, again, a clot is formed at the end of the catheter and then migrates into the patient's bloodstream. All right, for nursing information and safety, we want to make sure that we have a central line dressing at all times with a biopatch. You also want to make sure that you assess the PA catheter site, just like we do for all of our lines, assess for infection, redness, make sure your dressing is intact or up to date. You also want to include the catheter insertion site, the external centimeter mark like I just talked about. And then we want to make sure that if the balloon is in the deflated and locked position, because that's why we want to keep it at all times if the balloon is not in use. And then We want to always continuously monitor our patient with the EKG while the PA is in. Just to reiterate, really want to be vigilant about assessing for dysrhythmias. The proper PA waveforms, like I talked about earlier, if you have, if the catheter migrates or whatever, you could send your patient into VTAC, and that's really unsafe for the patient. Then you also want to make sure that there's no blood in the balloon syringe, because then the balloon has ruptured. And migration of the catheter, like I said, this could cause imminent death to the patient, and we don't like to do that here. All right, one more thing, only a provider can manipulate or reposition the catheter. So if you notice at any point the catheter has migrated or is unlocked or anything like that, just get the physician ASAP. And then at all times, our patient needs to be in bed for the removal or manipulation of the PA catheter. So that means do not allow anyone to remove a catheter at any point when the patient's either in the chair or with their head of bed up. One more thing, this is a big warning for everybody. Under no circumstances are we going to wedge our CT surgery patients. So, well, all of our patients come out with a swan from the OR, but that wedge part or that balloon part we just don't use once they get here to our unit. Only the surgeon may perform this task. No other physician can do that. And the reason why is because the balloon could rupture suture lines of the heart that they just operated on, as well as decrease blood to the valves, or if they had valve surgery, or just basically cause complications to the surgical site, and we don't want to do that. Okay, so now what we're going to move on to is how we actually wedge the catheter. Just wanted to point out to everybody that sometimes we interchange the words PA wedge or PAOP. And basically PAOP means the pulmonary artery occlusion pressure. And basically they're the same thing. All right, once we're going to go wedge our patient, we want to make sure that we remember that positioning is really important. The patient needs to be in supine position with the head of bed anywhere between 0 to 45 degrees. And then we want to make sure our transducers are level, just like we do at all times, to the fourth intercostal space mid-axillary line. And the reason why this is so important is because the PA and the RA waveforms, or excuse me, pressures, are more accurate in the supine position and with the transducer correctly leveled. And then just so I threw in the normal value of what a wedge pressure is, it's 8 to 12 millimeters of mercury, or 1 to 4 less than the PAD. All right, so now we're going to actually wedge and perform the procedure. What you want to do is go to your monitor. You're going to select the PA section here. Then you're going to have this option that comes up, all these options that come up. The first one you want to select is a PA insert or wedge. And then you're going to go to mode, and you want to select auto. The next thing you want to do is select new wedge. And then you're going to wait for the monitor will actually change right here and say inflate balloon. And when it says inflate balloon, it's ready for you. Next thing you want to do is draw up the 1.5 cc's of air in the balloon. Unlock the balloon port, which means that the red lines match up. Inflate the balloon with the air slowly, observing as the waveform changes from the PA to wedge on the monitor. And you can see right here, we go from PA to the wedge waveform. So now that the balloon is inflated, you only want to keep it there for 8 to 15 seconds or 2 to 4 breaths or respiratory cycles, no longer than that. And then you wait for the monitor to read the wave, or basically read the wedge, and it will say wedge processing. Alright, now that we've moved on from wedge processing, you want to allow for the balloon to passively deflate and lock the balloon port, which means that the two red lines do not match up anymore. And then you want to notice on the monitor you have the return of your PA waveform. After the balloon is completely deflated, the monitor will read wedge complete. And then this PA wedge review screen will appear. On the PA wedge review screen, you want to move your cursor to basically go right here to move wedge cursor to the A wave during end of expiration. So this just shows you, and use the scroll knob till you find the right marker, and then that will be your PA wedge. So where is the A wave? So basically, if you have a spontaneous breathing patient, you can read your pulmonary artery pressure, occlusion pressure at the end of expiration, at the top of the A wave, or basically at the highest point of the waveform. So right here is your A wave. So you measure it right here, the top of the waveforms. And then if you have a ventilated patient, you read your pulmonary occlusion pressure at the end of expiration at the top of the A waves or at the lowest point. So basically right here. And we call that ventilator valley. Here's another example of the screen where you would move your wedge cursor and you move it down here, and the wedge on this one is 15. Once you've obtained your wedge, what you want to do is print the wedge graph by selecting Graph Go Stop on the monitor, and then go obtain your printout. You want to document the wedge on it, sign and place the printed waveform graph in the patient's chart. Now that you're done with the balloon, what you want to do is lock the balloon port, which means that the red lines do not match up anymore. You want to remove the syringe and empty out all of the air, reattach, and leave it as. This is another example basically of where the pulmonary artery is and how the catheter is, the balloon is inflating during your pulmonary occlusion pressure. And then here's another example of the waveform changes. Here on this screen, just basically shows you the difference between the A and the V waves. So you can see here we've got some V waves, and we've got the A waves right here. Here's a PA wedge example. So you have the PA waveform here, and then you're in the wedge position. And the wedge was around 10 at that time. Here's another example where the wedge is around 6. Another example, or another 2 examples actually. And then I'll give you guys a second. We'll go ahead and measure the wedge pressure on this one. So here's your A wave. This patient is ventilated. Here's your scale. Go ahead. All right, hopefully everyone got 6. That's the right answer. All right, now we're going to move on to removal of the catheter. Only an ICU provider can remove the Swan-Ganz catheter. Just note that if an intern or resident is there to remove the catheter, they need to be supervised by either a fellow attending or RNP. Now, what you want to do is transfer any infusions over to the cordis or any other IV access that you have. You want to disconnect any stopcocks, disconnect anything that you don't need anymore to the Swan. Now you're ready for the physician. What you want to do is ensure that the balloon has been completely deflated and is in the locked position. So you want to go ahead and take the balloon. You want to unlock it, meaning the red lines are matched up. At this point, you may pull back on the plunger to remove any air that may be left in the balloon inside the patient at only this point. And then you want to quickly lock the balloon port, meaning the red lines are not locked up, and remove the syringe. Squirt or remove any air that's in the syringe and reattach to the balloon port. Now you may notify the physician that the balloon has been completely deflated.
The balloon has been completely deflated.
Sometimes the physician wants you to actually do it again and repeat that step. You can go ahead and do that if they request.
Can you do that again?
Okay. The balloon has been deflated.
Next thing you want to do is just make sure your patient's in Trendelenburg and they can go ahead and remove the catheter. So once they're ready, you want to make sure that you ask your patient to hum or hold their breath. So they go or hold their breath. And then the provider will remove the catheter with a constant steady motion. And you want to ensure that this happens because if they get stuck or stay in the RV for too long, like I said before, it can cause arrhythmias, including VTAC. So once they remove the catheter in the steady motion, you want to be watching the monitor to make sure that you don't have any changes or PVCs or whatever ectopy. And then once the catheter is removed, you want to make sure that the provider places a sterile obturator over the cordis here. Then you want to also apply a new central line dressing and document that the catheter was removed. In some cases, additional IV access is required, and sometimes the physicians may place a triple lumen or what we call slick catheter through the cordis. Also has a locking mechanism, also has a Cathguard contamination shield, and then you have 3 ports that you can use for infusions or whatever you need to use them for. Just keep in mind that that catheter itself should be charted as a new insertion, and you can place it under the cordis documentation in Pisces. What questions do you have for me? If you have any, please go ahead and see myself, Evelyn, Paul, or Tiffany, and we will be happy to answer your questions. Thank you.